Good evening. My name is Clark Britton. I'm a board-certified gynecologist and have a practice called Vibrant Life in Bloomington, Indiana. Tonight we're going to cover some topics that are dear and near to me, that are near and dear to many other people. Hormone therapy for men and women as they advance in age throughout their life. I'd like to give a shout out to begin with to my office staff. I've got the best staff in the world, I think. I have a manager named Heather Lindsay, who is an LPN and has been my office nurse for 23 years. That's a remarkable duration of loyalty. She really does a great job. She knows the practice, she knows the patients. She's assisted in the front office with Heidi Elliott and Ginger Sparks. And our medical assistants, Allie Davis and Sadie Fuller, help with direct patient care, as does our nurse, Jenna Kelly, who also does some of our aesthetics, and our nurse practitioner, Sherry Evans, who visits us a couple days a month. And we have another nurse who works for us part-time named Mallory Slaughter. These are wonderful people who do a fabulous job. They're intelligent, they present themselves well, they answer questions, they make people comfortable, and they're a real credit to our practice. As I mentioned, the goal tonight is to give you a brief review of hormone therapy for women and men as of 2025. There's been a lot of controversy in the last few years that was precipitated by a large study performed by the National Institute of Health called the Women's Health Initiative. And that study gathered a lot of publicity because it included a lot of women. There were about 27,000 women who were in three different arms of the study: a placebo arm, meaning no treatment, an arm of women who got a synthetic estrogen with a synthetic progesterone, and then a group of women who got a synthetic progesterone all by itself. The study was scheduled to go for 7 years. It terminated at 5 years because they noticed that there was a non-statistically significant but a slightly increased risk of breast cancer among the group of women who were taking the synthetic estrogen with the synthetic progesterone. That study arm was discontinued and published, and the public and most physicians incorrectly interpreted that as estrogen causes breast cancer. Simultaneously, the group continued the two arms of the study with the placebo and the synthetic estrogen by itself. That went on for another 7 years, and after 13 years of that study, they noted that the women who took estrogen only had greater than a 20% reduction in incidence of breast cancer compared to the women who took nothing. So that study was incorrectly interpreted and published, and for 20 years, the public believed that estrogen was a cause of breast cancer. Well, we've got a mountain of evidence since then to support the notion that estrogen, particularly in its natural form of estradiol, does not cause breast cancer, and in fact can safely be taken by women who are actively being treated for breast cancer under certain circumstances. So, what does hormone replacement therapy consist of? We'll start with men. How do you feel? Many men, as they age, have a decline in testosterone, which helps with strength, endurance, muscle mass, mental clarity, energy fatigue, brain fog, and sexual desire. Who doesn't want all of that? But as we age, most men find that they lose testosterone at a rate of 1 to 2% per year or more, depending on circumstances, by the time they're in their mid-30s. So by the time they're 60 years old, they've lost 30, 40, 50% of their natural testosterone production, and that results in a loss of all of those things that it helps: strength, endurance, muscle mass, mental clarity, energy fatigue, brain fog, sexual desire. And what we end up seeing is sluggish men, sluggish relationships, sluggish work, and frustrated men who are not achieving their maximum potential. There's a treatment for that, and we're going to talk about that in a minute. Women, instead of doing this, tend to fall off a cliff. So you've heard of women going through the change. Now, what does that mean? That means that estrogen levels and testosterone and progesterone that are naturally produced in great quantities during their reproductive years are starting to decline. The decline, which causes a number of symptoms while they're still having menstrual cycles, is called perimenopause. Menopause means no more menstrual cycles at all. And why is that important? Well, because estrogen particularly helps with hot flashes, night sweats, concentration, memory, mood, anxiety, irritability, vaginal lubrication, skin texture, joint lubrication, dry eyes and sleep, and some other stuff. But the reason it does all these things is because in our bodies we have 37 trillion cells. So the skin, the blood vessels, the bone, the brain, the internal organs, all have cells in which these hormone receptors reside and help the body function properly, so you can have changes with your skin and your hair and your bones and your blood vessels and your genitals because of a lack of estrogen and testosterone and progesterone. What we see in general is a gradual increase in hormone production during puberty. Reproductive years, it kind of goes like this. Perimenopause, like this. Menopause, like this. During the course of this reproductive life cycle, then there are hormone changes every month that allow women to become pregnant or have a menstrual cycle if they don't become pregnant. And the hormone levels are rather interesting because there's an initial spike in estrogen, then a decline, followed by a spike in follicle-stimulating hormone and luteinizing hormone that stimulate ovulation, followed by a slight increase in estrogen and a bigger increase in progesterone, which, if there's a pregnancy, helps support the early stages of the pregnancy. What most people don't recognize, though, is that during the course of all of this stuff, in the background, and not so much in the background, actually in the foreground, testosterone production is continuing at a pace higher than the highest levels of estrogen or progesterone. So during the reproductive years, the average woman is making 5 to 10 times more testosterone than estrogen every day. It's not just a male hormone, it's a human hormone. And this is a huge aspect in healthcare that a lot of people are not aware of. So if you look at a hormone graph for women, it goes like this: perimenopause, menopause. Men go up like this and then gradually down like this. So women kind of fall off the cliff and they notice all these changes all of a sudden. Men, it's a little more subtle, and finally, if they have that loss of 1 or 2% a year, one day they wake up and they, gee, things aren't working as well as they did. What can we do about this? Well, there's several estrogen products for women that are promoted to help with these symptoms. There are a number of FDA-approved products for women. There's pills, patches, creams, lotions, troches, which are little capsules that you dissolve under the tongue, injections, vaginal products, and then there's Sotopelli. And I'm going to talk in more detail about Sotopelli in a little bit, but it's hormone pellets that go underneath the skin and give you slow release, steady state dynamics of estrogen and testosterone to support those symptoms that happen because of a lack of hormones over a period of time much greater than you can get with patches and creams and gels. This is a slide of the FDA-approved testosterone products for men. Now, we think of testosterone helping men be strong, but it also helps women be strong. So, of course, for men, we have Androgel, Axiron, Androderm, Testim, Fortesta, Zeglo, testosterone cypionate, testosterone enanthate, Testopel, testosterone generic transdermal, Jatenzo, buccal compounded, topical compounded, and subdermal Sotopelli products for men. It's a little sobering, but I'm going to show you the FDA-approved products of testosterone for women in the world. None. There are no FDA-approved testosterone products for women anywhere in the world, even though throughout the reproductive years, testosterone is the dominant, meaning the most abundant ovarian hormone that women make for 40 years of their lives. People are working on this, and it's finally being recognized by a lot of influencers and a lot of important sexual health people that women need testosterone just as much as they need estrogen and progesterone as part of their overall physical health, mental health, and sexual health. And sexual health is health care. Well, in the Women's Health Initiative, a synthetic progesterone was used in conjunction with the synthetic estrogen, and in that group of women, there was a slight increase at risk of breast cancer, even though it wasn't statistically significant, but it scared everybody away from using estrogen, even though the culprit was synthetic progesterone. So in our practice, we only use micronized progesterone for our patients who take progesterone. Who should take progesterone? Well, most women, because it's, first of all, it's one of the essential hormones of the reproductive era. So your body makes estrogen, progesterone, and testosterone every day during the reproductive lifespan. In menopausal women who take natural progesterone, we see them have less breast cancer. They have better brain health. They have better bone health. They have calmer mood, and it helps them with sleep, just as it does during their reproductive years. There are some synthetic progestins that are still used, which in my mind shouldn't even be allowed because they are known carcinogenic, but medroxyprogesterone as a tablet or injection and norethindrone, which is a pill, that are still used to protect the lining of the uterus among women who take hormone replacement therapy and still have a uterus so that they don't bleed or develop uterine cancer. You can achieve the same goal using natural progesterone, which is done throughout the 40 years of the reproductive lifespan, so why wouldn't it be done in menopause as well? A lot of doctors were taught to use these synthetic progesterones, which were developed in the 50s and 60s, because they were a little stronger perhaps than the natural progesterone. This is a pretty sobering slide. You've maybe heard of hardening of the arteries or atherosclerosis or people developing coronary artery disease. Well, this slide depicts the progression of the inside of a blood vessel over time. Naturally, the progression in people who don't take any kind of hormone replacement therapy is that there's a healthy blood vessel that will develop a little fatty streak, and then that fatty streak turns into a plaque and a bigger plaque, and then that plaque can rupture and cause a blood clot, heart attack, stroke, etc. Women who take hormone replacement therapy early in their life, at the time of perimenopause or shortly after menopause, actually don't develop that plaque formation the way women who don't take any hormone replacement therapy do. Significantly, women who don't take any hormone replacement therapy and then begin taking hormone replacement therapy at a later time, typically after 10 or 15 years, still go on to develop that plaque. So that's not only the coronary arteries, but it's the brain, the genitals, the internal organs, the skin. All of these blood vessels are pretty small. Even a coronary artery is only 3 to 4 millimeters in diameter, so it's only about this big. Think about what happens if you develop a plaque. The blood that flows through there has to exert more effort to get through that narrowed chamber, that narrow passage. And that's what leads to hypertension, it leads to heart attacks and strokes, kidney failure, and so forth. And so if you really want to be assertive about prevention, then it's really imperative to be taking these hormone therapies early and continue it throughout the rest of your life. So among the things that happens when estrogen levels decline is there's skin changes, there's dry eyes, vaginal dryness. And why does that happen? Well, it's because estrogen fulfills the health of these tissues. There's estrogen receptors in all 37 trillion cells. And they promote health. So when in menopause, When there's a withdrawal of estrogen, the uterus starts to atrophy. It gets it shrinks basically, and the natural thickness of the lining of the uterus declines. The natural lining of the vagina goes from being elastic and lubricated to thinned out and stiff and leathery, and it just doesn't work well. Here's a picture, if you will, of a comparison, a mirrored view of a healthy uterus and an atrophic menopausal uterus, vagina, and ovaries. So the estrogen and progesterone and testosterone concentrations allow the uterus to have this healthy appearance. Nice thick muscle, the lining is luxurious, the ovaries are healthy. The lining of the vagina is this elastic tube. Think about it. You can get a baby to come out of there. So that means there's an enormous amount of elasticity to allow a 6, 8, 9-pound baby to pass through that area and then return to normal, where you can have a functioning vagina that allows for intercourse. It's a remarkable organ. However, in menopause, it loses this elasticity, it loses the folds of tissue, it loses the lubrication because of a lack of estrogen and progesterone and testosterone. And so you get a stiff, leathery vagina that is resistant to penetration, if you will. The uterus behaves the same way. And here's a little different depiction of that, just the vagina itself. So on this side over here, on the left, in your view, here's the cervix, here's the vaginal wall. The lining has these folds of tissue that act sort of like an accordion. Think about a guy playing an accordion that opens and it closes, and opens and it closes. And think about that in terms of accepting a penis with intercourse, or a toy, or a baby coming out of that passage, how it has to be able to expand and give and then contract again. And that's what happens with adequate hormone levels. With withdrawal of the hormone levels, the lining gets thinned out, the folds of tissue disappear, the blood supply is diminished. And so things just don't work as well without hormones as they do with. So again, there was this moment in time, well actually 20 years of time, when people thought of estrogen and said, oh my gosh, just don't take it. You can't, it's not good for you, it's going to kill you. But there's been a mountain of evidence since 2002 to show that there are significant benefits of estrogen. Think about this. When you're 30 years old, your body makes a bucket load of estrogen and testosterone and progesterone, and it's good for you. If it weren't good for you, you wouldn't make it. And just because you quit making it doesn't mean that it's no longer good for you. It's just that because we're outliving our reproductive capacity, that we are outliving the functional utility of our reproductive tract. But that change that happens to the reproductive tract is also happening to our brains and our heart, our internal organs, our muscles, our bones, and they suffer the consequences of diminished hormone concentrations as well. So, as it turns out, if hormone replacement therapy is done properly, guess what? Less breast cancer, less colon cancer, fewer heart attacks, less Alzheimer's, less osteoporosis. And in large studies that combine data from smaller studies, it's been shown in this meta-analysis, it's called, that you can diminish the risk of death from all causes taking estrogen and testosterone properly. 50%. Separately, women feel better, fewer heart attacks, fewer hot flashes, fewer night sweats, less trouble with concentration, irritability, memory, mood, and anxiety, better vaginal lubrication, skin texture, joint lubrication, dry eyes, and sleep. Who doesn't want that? And with proper hormone replacement therapy, that can be obtained. Testosterone benefits are no less important. Strength, endurance, muscle mass, mental clarity, energy fatigue, brain fog, sexual desire. And this is for women and for men. Men make a lot more testosterone than women do, but women make more testosterone than they make estrogen. Men make more testosterone than they make estrogen too, by a higher ratio than do women. With testosterone, we see less heart disease and heart attacks, proven. Less dementia and Alzheimer's, proven. Less depression, improved bone mineral density, less type 2 diabetes, and less colon cancer. Who doesn't want that? And I just threw up here on our slideshow a picture of what testosterone looks like and what estrogen looks like. And you can see there's some similarities in their structure. And as it turns out, testosterone actually gets converted to estrogen in the body, so that when you take testosterone frequently, some of that becomes estrogen to support all the things that estrogen does: fewer heart attacks, less Alzheimer's, less osteoporosis, and so forth. It's huge, and it's largely misunderstood or ignored by lay population and the public. So that gets us to, how do we take care of this? Well, it sounds simple. Take some estrogen, take some progesterone, take some testosterone. And it theoretically, it really is pretty simple, but the devil's in the details. So it's pretty common to think of, let's use a cream and put it on our skin, and we'll get some estrogen, progesterone, and testosterone. That's great in concept. However, the problem is, if you look at my skin, and you look at your skin, and you look at your neighbor's skin, and you look at your cousin's skin, it's all different. So the ability of your body to absorb that medicine is different from one person to the next, and there's not a reliable rate at which those medicines are absorbed. And even if they are absorbed, they have a really short half-life. The half-life of a topical estrogen, testosterone, progesterone cream is about 4 hours. So if you want it to last 24 hours, guess what? You got to use it a lot, frequently, and in large concentrations if you want to get a proper blood level. One of the problems that we see in a lot of practices is the patient will come in and they'll say, gee, I want some hormones. Well, here's your cream. Have a nice day. And not do any monitoring to find out, how do they feel? What do their numbers look like? And that's one of the things that we do with the hormone replacement therapy with Sotopele. Everybody gets monitored. Everybody gets surveillance of how do they feel? What do their numbers look like? The patches and creams have a real short half-life. The hormone pellets give us a half-life that's no different, but there's a constant release of the hormones underneath the skin that gives you sustained levels of estrogen and testosterone over several months at a time, as opposed to just a few hours. It's a night and day difference in how the body feels, because instead of getting a quick release of hormones for a few minutes or a few hours and then nothing, and a little release and nothing, you get a steady state release, and so people feel better, and their blood levels are better, and their outcomes are better. So just anatomically, it's important to note a couple things. The clitoris is kind of considered the heart and soul of the orgasm system for women. This is what it looks like. It's not just this little button here. It's all of this as well, these tendrils, or crus they're called, that extend down on either side of the opening of the vagina. In addition to this, there's about 11,000 nerve fibers that coalesce right here to make this the most sensitive part of the human body. This can be sensitive too, but with the aging process, guess what? It withers and weathers and diminishes in luxuriance. And so when women come to me frequently, they're saying that they're having trouble not only with desire, but with function. And part of that is because this organ is not getting the blood supply that it wants to have to function properly. About three-fourths of women report that in order to have an orgasm, they need clitoral stimulation. What's the value of an orgasm? Well, most people know what that is, but there's scientific evidence to show that it improves the immune system. The pellets that we use are relatively small. This is a male pellet, a 200 milligram pellet. It's quite a bit bigger than the women's testosterone pellets that are anywhere from 10 to 100 milligrams in size. This is a 200 milligram pellet. These are questions from live audience members. So, am I too old? Well, no. No one's ever too old to take hormone replacement therapy. It's just that if you're a little older, you may not get as much benefit from it. You saw the slides of the blood vessels. It's best if you start early and continue to take it. Then if you don't take it for a while and then start taking it, you don't get the full benefit. You'll still get relief of hot flashes, night sweats, concentration, memory, mood, and all that. But the physiologic changes that are shown to be beneficial with hormone replacement therapy are going to have a harder time to correct the withering and weathering that happens if you delay. I hope that makes sense. Another question I get, when do I stop? Well, the answer, the short answer is never. The more sophisticated answer is, how long do you want to feel good, and how long do you want to have this hormonal protection? And for most people, that's, well, yeah, as long as I'm functional. And that's the answer. I have 90-year-old patients that do sotapelli hormone replacement therapy. They feel great. In fact, one of them recently asked to have her testosterone level increased a little bit. So you're never too old. So what about balance in relationships? So what if the wife is way down here with libido and the guy's up here and there's this friction in the relationship? So a woman comes to me and says, gosh, I'm run down, no libido. What can I do? So we talk about some of these things like we've talked about tonight. And sometimes the answer is to include testosterone in the hormone replacement therapy. You made a lot of it when you were 30, and it was good for you. You made a lot of it when you were 40, it was good for you. You made a little less at 50, it's still good for you. Make a little less at 60, it's still good for you. We're just giving you back what you would have been making back in the day. But if that gets you from here, and your husband's here, or your partner's here, and you're up here, and now you're kind of matched up, that's great. But if you're up here and then he's down here, that may not be so good. So we kind of take a look at these issues with relationships, and as it turns out, we have a lot of couples that come in together because they want to be matched up. I have a lot of patients who are they're down here and they're happy with that. Their sexual excitement is to hold hands or a kiss or an embrace, and that's fine too if they're both happy with it. But we see so much conflict and so many relationships that wither and weather away at midlife because she's here, he's here, or they're both down here and neither of them happy with it. So we're simply restoring the hormone balance and concentrations of more youthful times. So is this for everybody? There is nothing that's for everybody other than food and water. So whether you do hormone pellets or one of these other things that I think isn't quite as good, it's better than doing nothing. So I tell all my patients, do yourself a favor, don't do nothing. Do something to help your body have homeostatic hormonal environment that's good for you. Other questions I get are, well, what about side effects? Well, anything you take can have a side effect. You can drink too much water. And so we try to have a balance in what we do. We have a fairly unique system. In fact, the hormone pellets that we use were invented in France in 1935. They were brought to this country in 1937 by a brilliant physician named Greenblatt, who was head of chemistry and reproductive studies at the Medical College of Georgia in 1937. And it's been improved. In the late 80s, a guy out in Scottsdale, Arizona, was a gynecologist who saw this and realized that this could revolutionize his hormone practice. He modified it and termed it sotopelle, which is Italian for under the skin. And for what it's worth, I'm the national medical director for sotopelle, so I guess they think I'm doing a pretty good job. And we have a very large hormone practice that includes sotopelle as the treatment plan. So he included a way to calculate how much hormone replacement therapy a person might need, men and women, what kind of labs to obtain to monitor it, and what kind of symptoms to anticipate, plus what to do about potential side effects. What are some of the side effects? Well, if you take too much testosterone, you can imagine getting road rage and being angry. Well, we don't do athletic performance enhancement. We do physiologic replacement therapy. So that athletic performance enhancement is off the table. So we have people that come to us and they want blood levels that are sky high. We don't do that. Go to a different practice if that's what you want. But some people who take testosterone do get a little edgy, so we lower the dose. We monitor everybody that we see with initial labs. We do labs after the first pellet insertion, maybe another time or two, to determine what their numbers look like and how they feel in relation to those numbers. So I tell everybody, nobody knows how you feel. You are the only one who knows how you feel. I can tell you what I think you might feel like by looking at your labs, but that doesn't translate exactly to how you feel. So everybody that we see gets monitored, and we review with them every time we see them, how are you doing? Side effects, things that we can improve, what do you think you need? And so the other thing that happens with testosterone excess, and this is, I think, probably what discourages a lot of people and a lot of physicians from prescribing it. There was a time when we thought you take testosterone, you're going to get a heart attack. You take testosterone, you're going to grow a penis. You take testosterone, you're going to grow a beard. Well, there are potential side effects from overtreating with testosterone, and sometimes that is a masculinizing effect. We don't want that, and most of our patients don't either. So if there is some hair growth, there's ways to combat that. If there's a deepening voice, that means you're taking too much testosterone. If you get acne, it may be too much testosterone, or it may be just your body's awakening to a little more plumping of the skin and activating those pores that have been kind of quiet. So there's things that can be done about that. But we communicate regularly with our patients. We have a wonderful staff. I mentioned our medical assistants, Allie and Sadie, our nurses, Mallory, Jenna, and Heather, have a huge fund of knowledge about how these hormones work, and they know our patients. So Mrs. Jones calls and says, hey, Allie, I'm having this problem. A lot of times Allie can answer that question. If she can't, she refers it to me. And so all of our patients are really feeling satisfied that our care of them matters. What we do for them matters. How they feel matters. And it's almost like having this enormous family of people that we see on a regular basis every 3 or 4 months for pellet insertion, and we're getting to know them and their families and their lives, and it's a really wonderful experience. So we do see side effects like that, but we deal with it. Now, one of the more common side effects is a woman who's had no hormones for a long time, and she has tissues like this, where the uterus has atrophied, and the lining that used to be there has disappeared, and the lining in the vagina that used to be luxuriant has disappeared. And we give them hormone replacement therapy. And what I tell them is, think about a house plant you forget to water. It kind of does this. Give it a big drink of water and it does this. Well, if that's you and your body, and it happens too quickly or too vigorously, it may be awkward or uncomfortable. You may feel like you're swollen here. You may feel like you're grumbling in your tummy. You may feel like you're full. And so we go from this to this, the thinned lining to a luxuriant lining. Sometimes there's some bleeding. Most of the time, it's due to an imbalance between the estrogen and progesterone that we use. We only use bioidentical progesterone. We only use bioidentical estrogen. Most of our patients take their estrogen in the form of pellets. Most of our patients take their progesterone in the form of a pill. So we balance those two things to help keep a homeostasis between what the body wants to be healthy and what might be excessive. We monitor blood levels and we monitor symptoms. Well, I hope this helps you understand hormone replacement therapy. We'd love to hear from you. I'm Clark Britton at Vibrant Life in Bloomington, Indiana. We have a presence on Facebook, Vibrant Life. We have a presence on Instagram, Vibrant Life B-Town. www.drbritton.com is our website. And you can call us at 812-331-9160. Our staff is available and willing to help anytime. Thank you very much.